Good evening, everyone. Warm welcome to this ninth episode of Nephro Live. In this session, we are going to deep dive into the common mistakes while managing CKD. And we are having eminent panel of experts today to guide us how effectively we can manage CKD patient by avoiding these common mistakes. And to guide us today and moderate today's session, we're having with us a legend, an icon in the field of nephrology, Dr. Dinesh Pullar sir. He's currently chairman and head department of nephrology and renal transplant medicine at Max Superspecialty Hospital, Saket, New Delhi. So with this word, I hand over the session to Dr. Dinesh Pullar sir and request him to introduce our faculty for today's program. Over to you, sir.
Thank you very much, Dr. Mithlesh, and thank you once again, Intas, for this wonderful opportunity to allow us to connect to our wonderful friends across the country. As we all know, this endeavor, ably supported by Intas, has the initiative is to spread the message about chronic kidney disease. What we as nephrologists would love everyone across the country who are dealing with patients with any kind of chronic kidney disease ailment, who need to know about the absolute basics, so that we are in sync with the contemporary world as to what we can offer in 2025 to our patients suffering from this menace of chronic kidney disease. We've had some very successful additions. I am always honored to have country's topmost nephrologists, my most dear friends, who never ever say no to us, and they are equally supportive of this initiative. And today, let me tell you, is going to be no exception. We have some of country's best nephrologists one more time to take you through this journey of management of chronic kidney disease. So we are going to be having Dr. Sahil Bagai giving us a talk on the common mistakes while we set about managing patients with chronic kidney disease. And you'll be surprised how often does it happen, inadvertently most of the time, but so many times it is when we tend to forget the absolute basics. So we need to remind each other that, look, it's our collective responsibility to be able to do the best for our patients and try to minimize making mistakes as far as possible. Sahil is I'm really honored to have him here with us today. I have had the pleasure of working in with him when he was there at Max Hospital Saket till some time back. A brilliant nephrologist who has a great academic career starting from here in Delhi, and then he moved on to PGI Chandigarh for his post-graduation, and currently he is working as senior consultant and head unit of nephrology at the prestigious Fortis Hospital, Manesar, Gurugram. So he has lots and lots of academic accolades to his credit. He received the TTS ISOT Transplantation Science Mentor Travel Award, and he was awarded a prize in the ISOT 2016 in oral presentation. He was awarded a second prize in the zonal rounds of Torrent Young Scholar Award held in Delhi in 2017. He's been a permanent feature of our nephrology conferences all over the country, and he has a lot of keen interest in publishing. Some of his articles which he published while he was there at PGI Chandigarh and here with us at Max Saket are really a treat to read. Thank you very much, Sahil, for accepting our invitation. And it's my pleasant task to introduce a very dear friend of mine, and it's an honor to have a Padam Shri awardee. That is Dr. Hemant Kumar, who is the president of All India Institute Medical Sciences, Gorakhpur. So I know how busy he was, but thank you once again, Dr. Hemant Kumar, for obliging by accepting our invitation for today. He
Thank you,
has.
Dr. Kullar.
Thank you very much. Honor is indeed ours, Dr. Hemant. Dr. Hemant, for those uh, who may not formally know him and may have just heard about his vast achievements. He has headed the Department of Nephrology at the prestigious Indira Gandhi Institute of Medical Sciences, Patna, and he's been the past president of Indian Society of Nephrology. His zone pioneered the 3P model, that means the pediatric, preventing, and palliative nephrology. And he is very passionate about this model. If time permits, maybe we'll ask him to just share his thoughts on that. He's credited with introducing the technique of CAPD in the state of Bihar, and quite appropriately, he's been awarded the Guru Dronacharya Award, and as well as the Lifetime Contribution Award and Award for Excellence in Nephrology by the Indian Society of Nephrology. So, thank you very much once again, Dr. Hemant. With your vast experience, I'm sure you will add value and just the right topic where we have to have an experienced person like you. Up next is another very dear friend, a very learned fellow, a treat to listen to him all the time, brilliant nephrologist by the name Dr. Sri Bhushan Raju. So thank you very much, Dr. Raju, for accepting our invitation. I know how busy you are, and I could actually see you heading back to home from your place of work, and certainly it's a big honor for us to have you here with us. He is the senior professor and head department of nephrology again at one of the best known institutes of South India, that's Nizam's Institute of Medical Sciences, Hyderabad. He has over 130 peer-reviewed publications in various journals of repute. He's been the regular examiner for the DM and DNB program all over the country, including the prestigious AIMS, SDPJ, PGMR, Lucknow and Chandigarh, delivered lectures at international and national nephrology forums. Again, a permanent fixture whenever we have any big conference come up. It has to include Dr. Shri Bhushan Raju's name as well. Well, he's recipient of many awards, and for his academic activities, he was actually awarded the Dr. H.L. Trivedi Gold Medal way back in 2002, various other prestigious awards to his credit. So again, thank you very much, Dr. Raju, for joining us today. We're going to miss my very dear friend, Dr. Kubesh Modi. Unfortunately, he was all set, but at the last minute, he's developed very high-grade fever. So we are wishing him quick recovery. I know how keen Gupesh was. For those who may not know Gupesh, another brilliant nephrologist trained abroad as well. So he's a nephrologist at some urban hospital and kidney care center, Bhopal, and he has more than 20 years of rich experience as nephrologist. And after his training from All India Institute in New Delhi, he went abroad to get trained in nephrology from the Tufts Medical Center, Boston, USA, and he has lots and lots of original research. Publications to his credit, and including he was part of that landmark Sikh trial where they came out for the first time, drawing our attention to the magnitude of the problem of chronic kidney disease in our country. Again, a very, very brilliant nephrologist. It's a treat to listen to him, his viewpoints, and a gentleman full of life. So I'm certainly going to miss him. But maybe we will rope him in one of the future editions just in case. I'm hoping against hope that just in case he gets better, probably he will try to join in. And last but not the least, we have Dr. Sudeep Sachdev. Next one, please. Can we have the next slide? Yeah. So Dr. Sudeep Sachdev, another brilliant guy. He is a director and senior consultant in the Department of Nephrology at another well-known hospital in Gurgaon, that is Narayana Hospital. Again, he has a great academic career. He received world-class training at All India Institute after his initial training from Delhi University as well. A recipient of multiple awards, and again, he comes across as a person with huge clinical knowledge and acumen, and so quite appropriately, he has many publications to his credit, including some well-known nephrology textbooks. He's quite well versed in practically all aspects of nephrology. Thank you very much, Sudeep, for joining in today. And I'm sure we're going to have a great discussion after
Thank you so
Sahil
much,
has
sir. Thank you.
given. Right, it's a pleasure indeed for all of us today. And again, let me remind, it's an initiative undertaken by Intas. A lot of hard work which goes into it, starting right from the top, Mr. Roda, and then ably led by Gaurav Khanna and of course Dr. Mithlesh, who leaves no stone unturned to make sure that the academic content of each and every meeting is up to the mark. So today we meet to, as I said earlier, to talk about some common mistakes which all of us, including us nephrologists, admittedly, I must acknowledge, do make while we are trying to manage a patient with chronic kidney disease. And sometimes these mistakes can be so dangerous that it can have wide repercussions in the outcomes. So I'll give you a small example. I mean, very, very easy things for all of us. A patient comes to you and is one look at the skin of the patient, you've immediately diagnosed the patient as having herpes zoster. And within no time, as a reflex, you will start prescribing either acyclovir or some allied congena, not realizing in the usual dose, not realizing that the patient already has advanced chronic kidney disease, whereby the GFR is already as low as something like 20-25 mils. Now what happens? You have prescribed, let's say, acyclovir 800 milligrams 5 times a day, and the dose gets accumulated in the presence of renal insufficiency, that on the third day patient gets admitted to the hospital, not in encephalopathy, not because of the CNS involvement of herpes zoster, but unfortunately because of the toxic cumulative toxicity of acyclovir. And then you curse yourself as to why didn't you to look appropriately at the GFR of a given patient before prescribing. Another very important things come to mind. Patient is complaining of nausea and vomiting, some kind of dyspepsia, and the and the physician believes it's dyspepsia and tries to give this patient the usual dose of levosulpiride. On the third or the maybe within a week's time, the patient could land up with a neurologist with severe encephalopathy. Same can happen with drugs like baclofen. Now, let me take a different turn. A patient of post kidney transplantation comes to his usual GP with fever, and quite appropriately all the proper work has been done by the treating physician, and he diagnoses it as a case of pulmonary tuberculosis. Now obviously one would believe that in India no one needs to teach any physician how to treat tuberculosis. It's well known to all of us. But here the catch is the patient is receiving drugs like cyclosporin or tacrolimus, which the levels get influenced by concomitant therapy with rifampicin. So much so that the levels can practically disappear from the blood once the adequate levels of rifampicin are there in the blood. So what happens? You may end up you may actually be able to treat tuberculosis quite well, but end up losing the graft function. So very a dangerous situation when you don't know the drug-drug interactions. I would also want to draw everyone's attention. So many times a patient is on azathioprine and now gets hyperuricemia. As a reflex, you may want to start allopurinol or febuxostat, not realizing the drug-drug interaction with azathioprine. Why I'm specifically referring to azathioprine is because of the fact that many of our patients in the field of nephrology, be it transplantation or otherwise, could actually be on not necessarily anything to do with their chronic kidney disease status, but this just came to my mind. I thought maybe I'll put forth my view as to what common mistakes come to my mind when we have it could be some macrolides, erythromycin, azithromycin, or drugs, or clarithromycin, again having drug-drug interaction with transplant medication. So it's extremely important for us to know the drug dose modification in the presence of chronic kidney disease, as at the same time know about the drug-drug interactions, so that we are able to do justice to our prescription and we don't harm our given patient. With that in background, I will now request Dr. Sahil to over the next about 15 minutes, tell us as to what other kinds of examples does he have in mind, and before that, elaborate as to why the caution, why does it happen in our patients, and where are we predominantly going wrong, so that we can make amends and try to ensure that we do it the right way. Over to you, Dr. Sahil, please.
Good evening, everyone. At the outset, I'd like to thank Dr. Fuller for having me here. It has always been an honor to share a stage with him. And I'd like to correct him that it was my honor to work under him. And it had been pleasure for all those years while I was in Maxakit. And I'll also like to thank Intas for having me here. So without wasting any further time, I'd like to start with the topic. So we will be talking about common mistakes while managing CKD. So we all know that chronic kidney disease, as per KDIGO, is defined as abnormality in structure or function of kidneys, which is to be present for at least 3 months, which has an implication on your routine health. We all know that for a patient with chronic kidney disease, we either categorize them into as per the glomerular staging, or we have categorization of them as per the albuminuria levels. So the patients can range from G1 to G5 as per the GFR, and they can range from A1 to A3 as per their albuminuria levels. So, talking about epidemiology of CKD and why mistakes matter. So, we all know that CKD is a global health concern. Majority of patients are asymptomatic until very late stages, which leads to higher morbidity and mortality. We all realize that many modifiable risk factors exist in a set of patients who work in our clinics: hypertension, diabetes, obesity, proteinuria, but we fail to address them at times. In India, referral to a specialist is always a concern and happens late in the course of the disease. We all know that kidney acts as a major route of elimination for many drugs, and hence dose modification may be needed as per EGFR, which has to be taken in concern whenever the patient is given some renotoxic drugs. Talking about diagnostic errors, which also are because the under recognition of CKD. So as I said that we all have patients who are at risk, hypertension, diabetes, and they probably have family history of comorbidities. But we don't ask them to be screened at periodically at specific times. We nephrologists know that the creatinine alone is not to be solely relied upon, but as of now, we don't have anything better than that. We know that cystatin C at times can help us, but then that's not standardized still in even the major centers of India. And let's not talk about tier 2 and tier 3 cities. We know that albuminuria as a routine is still not followed at many places, though of late in last decade, people have started to realize the importance of albuminuria, but at many places, this still lacks. There is misclassification due to ignoring the age of a patient, the muscle mass, the diet, the race, and ethnicity. So we all know that, as I just said, that we have creatinine and cystatin C at our disposal. So at times, inappropriate EGFR equations are used without knowing their limitations. Acute illnesses is a state where the GFR equations don't stand for. And as I said, we often end up ignoring the dietary effects or muscle mass, which have their own set of confounding changes in the values of creatinine. The life is not made easy by lab and imaging services. We know that there are quite a lot of errors which we encounter while coming up with the patients coming up to our clinic. So there are errors in interpreting the urine protein albumin results. Most of the labs in India are non-standardized, and hence there are a number of lab errors which happen. Radiology centers, in view of fear for attrition of patients, they unnecessarily image patients with contrast even without checking the KFTs at times, which I don't meant to say that happens in metro, but can still happens in metro, but tier 2, tier 3 cities, this is more often a norm. Talking about, are we good enough to monitor mistakes? So we know that we do not have our patients EGFR and monitoring done as per the guidelines. There is a definitive, unrecognized, and delayed worsening of immunity or proteinuria in our patients. We do not address or explain the patients for self-reporting of complications, which may be limited to anemia, mineral-borne disorders, and electrolytes. And we fail to review medication at transitions of care. Talking about therapeutic errors, so we all understand that the importance of GFRs while we prescribe drugs. So as Dr. Piller rightly mentioned, that even the nephrologists who believe that they do it right at all times, I would also agree that at times we fail. So inappropriate drug dosing in CKD in respect to antibiotics and analgesics needs to always be taken seriously. Not recognizing nephrotoxicity from some drugs or over-the-counter agents can be detrimental to the ailing kidneys. Polypharmacy always puts our kidney cohort patients at risk because there is a serious chance of drug-to-drug interaction. Lack of periodic check for drug accumulation, especially in cases of advanced stages of chronic kidney disease, can lead to potential problems. This was a paper published in Journal of General Internal Medicine 2021, wherein the Medicare data was taken, and it was seen that one third of the Medicare enrolled medication therapy management eligible patients with CKD were prescribed at least one potentially inappropriately prescribed medicine in this paper. And they saw that primary care physician providers were the people who were the most notoriously gave one drug at least for which was inappropriately dosed for our set of patients. So in this paper, it was seen that these were the common drugs which were air in the while prescribing. So allopurinol, etinol, digoxin, ofloxacin, betaxolol, amoxicillin, clavulanate, ciprofloxacin, and sulfamethoxazole primethoprim. So simple drugs like amoxicillin and clavulanate also was prescribed in the wrong doses, which uh, just is an eye opener that even a simpler drug, which everyone believes everyone would have used in globally, can also be a cause for errors in the drug prescription. So how do we take care of the doses? So we need to see the drug response. We need to be aware of the drug toxicity, and we need to be aware of the drug levels. So, talking in continuation about the therapeutic errors, there are also existing pitfalls in managing common conditions like diabetes. We know that most of our patients are referred late to the specialist, so there is definitely a delayed initiation of key therapies like SGLT2 inhibitors, GLP-1 RAs. There is an inherent fear of hypoglycemias with advanced CKD, which may lead to overly conservative glycemic goals without benefit, rather can be detrimental to the kidneys. Not adjusting doses of glucose lowering agents as per the dynamic changes in the kidney function. And at times, most of us would have seen that most of the physicians, the primary care givers, even some nephrologists, give SGLT2 inhibitors and GLP-1 RAs in type 1 diabetes, which is an off-label use and which is not backed by any scientific guidelines. Talking about common drugs which are used in diabetes, we know that metformin is not to be used in people whose GFR has dropped to less than 30. If the GFR is about 45 to 60, can be initiated on metformin, but obviously the vigilance is required. As soon as the GFR drops to 45, it should be a red or orange flag at least that the drug has to be monitored quite frequently. Talking about the backbone of the OHS, sulfonylureas, we all know that glipizide by far is the most common drug which can be used in all stages of CKD. It has the least propensity to cause hypoglycemia. Glimepiride has to be used with caution because it can cause alarming hypoglycemias. Glyburide has to be used in caution after the creatinine clearance falls below 50. Amongst DPP4 inhibitors, linagliptin, we all know, is nephrologist go-to drug. It's the favorite for all of us. Requires no dose adjustment. CETA and VILDA obviously will require dose adjustments after progressing from stage 3B onwards. Carbos has to be limited to cohort with GFR more than 25 ml per minute. And thiazolidine diones are generally renal safe. But since these have the propensity to cause fluid overload, these are not generally preferred, at least not by the nephrologists. Talking about SGLT2 inhibitors, so last decade has belonged to this particular molecule. It has deemed to be renoprotective, cardioprotective. Multiple trials have backed it. We all know that initially a physiological drop in GFR will occur. That's where the communication, if the communication is not done to the patient, attrition to this drug may happen with patients. Can be given to people with EGFR of, sorry for the typing error, to GFR up till 20, and can be continued until someone initiates on dialysis. The caution has to be fungal UTIs, genital infections, and has to be used cautiously in people with peripheral vascular disease. Talking about pitfalls in blood pressure management, so we all understand that different guidelines advocate different BP levels, but the sprint trial instilled confidence that the blood pressures of less than 120 by 80 are going to be better for our set of patients. Not individualizing BP targets leads to a majority of problem in our set of patients. Fear of using RAS. Post stop ACE, the outlook has changed in mainly the nephrologist cohort, but still the primary physicians and the internist fear using the RAS inhibitor. Inappropriate choice of agent irrespective of proteinuria, and as I said, there is an inherent fear of worsening of GFR, which is a physiological worsening use of agents which are non-RAS based. So what can we do for hypertensive management in our patients is we can reduce the salt intake. That's general dictum, 2 gram sodium or a 5 gram of table salt. General population is salt sensitive, almost half of them. CKD patients, majority will be salt sensitive, that is volume sensitive, and some would be hormone sensitive. So the only precaution these patients need to advocate in the diet is to avoid usage of low sodium containing salts, as these have almost 4 times high potassium load than the normal table salt which we have at our disposal. Talking about the use of diuretics in antihypertensive doses, so thiazide drugs are ineffective when used in beyond stage 4 CKDs. Chlorthalidone or thiazide-like diuretics can still be used in stage 4, stage 5 CKD, which as a nephrologist and as internist, we would resort to when our patients are in fluid overload conditions. As I said, metolazone, chlorthalidone, and indapamide can be used even in later stages of CKD. Loop diuretics is go-to agent for fluid overload condition, not a very potent antihypertensive effect. Potassium-sparing diuretics, they need to be avoided in stage 4, stage 5, and they usually have to be given once a day. And these are usually co-prescribed with loop diuretics. Talking about ACE inhibitor, so we understand that it's a double-edged sword. As I said, it's a renoprotective, but is also backed with a physiological decline in the EGFR in the early days. It's contraindicated in bilateral RAS. Can be started at lower doses if at all someone is uncomfortable at EGFR less than 45. A patient who is on NSAIDs diuretics, there can be a triple whammy effect. We need to be careful. Similar goes with the patient who is on SGLT2 inhibitors. The assessment of GFR and potassium has to be done, if not after 1 week, then definitely after 4 weeks. And if the rises of creatinine or the dip in GFR is more than 30%, that's the time when contemplation has to be made whether the drug needs to be stopped or not. If at all the slope of the GFR lies between the physiological fall, please do not discontinue your ACE inhibitors. That's what the stop ACE trial advocated. And they can say be safely started in patients as soon as they are back on dialysis, as most of the patients would require hormone inhibition for proper BP controls. Temporary withholding of ACE inhibitors may not be a bad idea if there is a concomitant contrast given. So to avoid contrast associated nephropathy. Whenever there is a volume depletion scenarios, then obviously ACE inhibitors or ARBs can be stopped and they can be restarted appropriately later. Angiotensin receptor blockers shouldn't be combined with ACE inhibitors. And then we all know that ARNI have their own niche whenever a patient has heart failure. Talking about antitubercular drugs. So in India, we can't escape antitubercular drugs still. We all know that isoniazid and rifampicin are liver metabolites, can be used in maximum tolerated doses. Ethambutol, pyrazinamide are renally excreted, and as the table shows that the dosage reduction for ethambutol will happen from 10 between 10 to 50 GFR and less than 10 GFR. So same goes for the pyrazinamide. Ciprofloxacin, levofloxacin given as a part of rifampicin sparing agents have to be given with caution. Renal excretion of 50% of the doses happen, so dose modification is required. Moxifloxacin, however, is safe enough to be given at routine doses. Talking about rifampicin, post-transplant, we all understand that rifampicin is going to induce, stimulate the metabolism CNIs. So CYP4, P450 induces, so the levels are going to reduce. So if someone is on rifampicin post-transplant, more often checking of the tacrolimus level has to be done. Other drugs which interfere with the post-transplant period, especially tacrolimus levels, are going to be anti-epileptics, which are going to be inducers of CYP P450. That needs to be given with caution. Macrolides increase the CNI levels. So azithromycin and clarithromycin, given as an atypical agents in pneumonitis, have to be carefully given if we are talking about post-transplant period. Talking about NSAIDs and PPIs, we all understand that there is a overhype of non-usage of NSAIDs in a group of patients. There were few papers in between which advocated scientific use of NSAIDs, but as a group of cohort will still condemn using NSAIDs to a group of patients. Proton pump inhibitors used in short time offer advantage, but on a long term will may lead to chronic interstitial nephritis. Dr. Kullar did mention about levosulfuride. So obviously, levosulfuride given to advanced stages of chronic kidney disease patients can lead to extrapyramidal symptoms. So one has to be cautious before advocating use of these drugs in later stages of chronic kidney disease. Talking about vitamin D usage, it's widely prescribed drug by all doctors across all medical specialties. Injectable vitamin D can at times lead to iatrogenic hypercalcemia, and use of active form of vitamin D in a set of population has to be taken with a pinch of salt, and it has to be given in accordance with the intact parathyroid levels and phosphorus levels. Vitamin C, as I said, I mean, it's usually harmful in the kidneys, can lead to oxalate formation and increased stone formation. So, for a patient with renal stone disease, this has to be given cautiously. Talking about statins, so amongst all statins, the atorvastatin is deemed to be more safer, but doses more than 40 milligrams may should be avoided. Rosuvastatin and fenofibrate can lead to rhabdomyolysis and myoglobinuria in these in our set of patients. So higher doses should be discouraged from usage. And even for fenofibrate, if the GFR is less than 60, more than 30, the maximum dose should be 67, not 145 or 160. Just a reiteration about the painkillers. As I said, NSAIDs are always going to be Achilles heel for a nephrologist. So we, as a community, condemn using NSAIDs. But as I said, wise usage of NSAIDs is not an absolute contraindication. Paracetamol and tramadol are which we usually advocate in our OPDs. Morphine, obviously, if someone is in patient, then obviously morphine can be given to these patients. Gabapentin and pregabalins can be used as nerve modulators, and they should ideally be started at lowest possible doses because they can induce quite significant sedation in a set of patients. So to summarize, I would say that early detection plus screening of high-risk individuals with albuminuria and use of cystatin C should be encouraged wherever possible. Guidelines supported therapies in form of RAS inhibitors and SGLT2 inhibitors, along with lifestyle modification, whereas quitting smoking and exercise should promotion of exercise should be advocated, and every target in our set of patients should be individualized, whether we talk about BP levels, glycemic levels, we talk about dietary prescriptions. So de-prescription should be done in form of NSAIDs and PPIs. Painkillers would always be an area of concern. ATT should be prescribed as single drugs. We as a nephrologist always condemn using dots, citing that these drugs become very difficult to manage. Low sodium salt should be avoided, and potassium sparing diuretics, if given for other comorbidities, should be vigilantly followed. ACE inhibitors, ARBs, are there to protect your kidneys, so should be prescribed in CKD and should be continued even in advanced stages of CKD. Anti-diabetics, metformin should be encouraged to use because as per the recent ADA guidelines, metformin has some cardioprotection. SGLT2 and gliptins have their own niche, should be used whenever and wherever possible. I would add GLP-1 RAs since they are the new kid on the block. They also have their own niche, should be advocated and used wherever the demands, wherever it mandates to be used. Talking about fat soluble vitamins, vitamin D is okay to take, but calcitriol, as I said, should be taken in, should be given in context with IPTH and phosphorus level, and vitamin C should be used cautiously if someone has a history of renal stones. So I like to thank here, and again, I like to thank Intas and Dr. Kulla for the opportunity. Thank you.
Well, thank you very much, Sahil. And I'm sure everyone would agree he has done complete justice to what we expected from him today. And what a nice and comprehensive overview of the way we should look at the dose. It's about, as he has rightly pointed out, about the drugs which should not be given, and then we should be equally concerned about the right kind of dosing in these patients. And of course, what I had said earlier is the drug-drug interaction, which makes it so very important. So he's touched upon all the relevant things, and that's something which we deal with on a day-to-day practice when it comes to NSAIDs. So a whole lot of mistakes are done when a patient innocently goes to let's say a dentist for a tooth extraction, and the other person not realizing that the creatinine was high, the patient is prescribed proper the usual dose of NSAID painkillers, and then obviously it's going to be detrimental. But at the same time, we should not always view a properly or conscientiously taken decision as something wrong. So many times we find ourselves as nephrologists prescribing NSAIDs. You see, because here is a patient who is in some kind of encephalopathy, and you may not want to give the narcotic analgesics. And here, a cautious trial with and a short course of NSAIDs may not be detrimental. So I think when it is something which has a decision which has been taken very carefully with all your proper knowledge into it, I think we should not unnecessarily criticize our colleagues who may have done it fully knowing what as to what they are doing. So what we are today referring to is the inadvertent mistakes, and so many times we miss out on these important issues. So that's why I thought personally that it's extremely important to recapitulate our knowledge about the various aspects of drug dosaging and modification in a patient with CKD. So another aspect which I always have in mind is looking at the prescription of aminoglycosides in a patient with CKD. So many times the patient may have a situation whereby that is which is amenable quite well with the aminoglycosides. So are you really going to stop yourself from prescribing aminoglycosides? Well, the answer may be no. There are two aspects to it. One, aminoglycosides can cause renal toxicity, and the other aspect is what do you do when the patient already has CKD and you're wanting to prescribe? And then, of course, the answer is to modify the dose of aminoglycosides rather than say put a blanket ban on the use of a very effective class of drugs. But yes, we do realize what I'm referring to are exceptions. Now that you have so very impressive classes of antibiotics, why would you ordinarily want to fall back on aminoglycosides in a given patient where you can do away with them? So let's not look into the anecdotal things or case scenarios. Let's look at the broad guidelines which tell us that we should be very, very careful prescribing, not just in patient with chronic kidney disease, but that holds true for any patient who comes in our contact, and we have to be mindful of the correct dosaging. So let's now have a great discussion. I'm quite excited to have my friends join us for a lovely panel discussion. So may I begin by asking Dr. Hemant. Dr. Hemant Kumar, see, we have discussed it in our previous forums that the way we should look at the diagnosis of chronic kidney disease. And then let me hear it one more time from you. So many times we look at only serum creatinine, which
Yeah.
does not tell us whether a given patient has AKI or CKD. All that it tells us that there is renal insufficiency. And obviously, in the context of chronic kidney disease patients, we extrapolate the information, put it into those formulae, and then come out with estimated GFR. And in the bargain, so very often we forget the relative importance of albuminuria. So one more time coming from you will certainly make a difference with all your experience. How would you guide the physicians who have joined us today to be able to make a diagnosis of CKD, keeping both in mind or just one of them? Yeah.
Yes, Dr. Fuller, am I audible?
Yes, perfectly well, sir. Please go
Yes.
ahead.
In fact, by relying only on serum creatinine, we may sometime miss early CKD. So patients, whoever are presenting with swelling of body, hypertension, anemia, and albuminuria must be subjected to EGFR along with UACR. Because unless and until we go for EGFR and UACR together, we cannot have a very good treatment guidelines and risk stratification. So for risk stratification decision and treatment decision, we must go both EGFR and UACR. And what newer KDIGO guidelines they have suggested, adding cystatin C and creatinine both to estimate EGFR for a more precise assessment of kidney function. I'm sure you are well answered.
Thank you very much, Dr. Hemant. This is exactly what we wanted to be conveyed to those who have joined us today. Very, very important. Sudeep, next one is for you. When we look at the electrolytes, and we do understand there are mistakes very commonly made. I have a very common scenario in mind. A patient of type 2 diabetes. We know these kind of patients can have type 4 renal tubular acidosis, which predisposes them to hyperkalemia. On top of that, they are given ACE inhibitors, angiotensin receptor blockers, which adds to this problem. And this is further compounded by the fact that they may have some cardiac issues, and the cardiologist may want to give them mineralocorticoid receptor antagonists, be it aldactone, spironolactone, or eplerenone. So with this kind of situation, if supposing they have some tooth issue, and by the dental surgeon they are prescribed NSAIDs. So I think this is typical sone pe suhaga wali baat. So what is your take on this kind of electrolyte imbalances, which go hand in glove with chronic kidney disease diagnosis, and how will you guide those who have joined us today to mitigate such a problem?
So, sir, as you have mentioned, the classical situation, this is a triple whammy with three drugs being given in the background of diabetic nephropathy, in the background of acidosis. So, there is a complex interplay in terms of the pathophysiology, chronic kidney disease, because the compensatory mechanisms for both sodium and potassium retention or excretion are lost respectively. So, it is extremely important that the various aspects are looked together in managing electrolyte abnormalities. For example, I would start with the staging of chronic kidney disease, at what stage we are dealing and at what stage the patient is having these abnormalities. Any EGFR of less than 30 would definitely predispose the patient to more hyperkalemia. And at this stage, even mild dietary non-compliances with addition of such drugs, such as you talked about ACE inhibitors, ARBs, would definitely precipitate hyperkalemia, which would be more subtle as compared to a healthy individual. Apart from this, we have to remember acid-base abnormalities. Hyperkalemia can also be due to metabolic acidosis, whether it is precipitated by, say, uncontrolled diabetes, or can be due to some toxin, poisoning, septicemia, or even renal tubular acidosis. So this will cause an extracellular shift of potassium from the cells and lead to hyperkalemia. So correction of hyperkalemia at this point would not be of much use unless you target the acidosis as well as the cause of the acidosis, which is there. Similarly, a situation where you have an intravascular volume depletion secondary to over diuretic dosage leading to alkalosis, which in turn leads to hypokalemia. So you have to target the cause, that is over diuretic usage, as well as the alkalosis, and then the correction of potassium as well. Also, you have to see the background of medication that the patient is on. So as we all know, patient could be on ACE inhibitors, ARBs, mineralocorticoid receptor antagonist, which could be spironolactone or eplerenone. So these drugs itself lead to hyperkalemia. So diagnosis of hyperkalemia in such patients should be looked upon in the background of these drugs. And if it is moderate to severe, then withdrawal of these drugs would probably be the first step, followed by the correction of hyperkalemia. Similarly, diuretics can lead to hyponatremia, and we know for treatment of early stages of in hypertension, in early stages of chronic kidney disease, thiazides are often started, or in late stages we use loop diuretics, and they can also precipitate hyponatremia with hypokalemia and even hypomagnesemia. Apart from this, most important thing that we should look forward to when we treat electrolyte abnormalities is the volume status of the patient. So as we know, as CKD advances to stage 4 and 5, there is a degree of volume retention or fluid retention, which in turn could also lead to dilutional hyponatremia, whereas as in the actual value of sodium in the blood is okay and the intake is okay, but the patient is having relative hyponatremia. So in such a case, targeting treatment of hyponatremia would not be the correct way to go, but we have to increase the free water clearance with diuretics, and fluid retention would probably be something which has to be looked forward to. Also, our patients are often obese, and one can say, difficult blood sampling is there. So pseudo hyperkalemia due to hemolysis, or, you tie the tourniquet for a long period of time is something that should also be kept in mind. And in last stage of the kidney disease, where the patient is on dialysis, is also a patient of chronic kidney disease. So if he misses a session, or there is inefficient or inadequate dialysis leading to hyperkalemia, or maybe, so in that case, whatever measures we take would be inadequate because the patient is oligoanuric. So maybe giving proper dialysis treatment would be the correct way to go. And in the background, also rule out other causes, because CKD patient could also be having diarrhea leading to GI losses, or maybe hypoaldosteronism, as you mentioned, for tubulointerstitial diseases or for diabetic nephropathy. So all in all, look at the volume status along with the acid-base balance, rule out pseudo hyperkalemia, and look at the other drugs that the patient is on, along with the baseline, whether the patient is still hypertensive or normotensive, and these factors play an extremely important role.
Quite appropriately said. Thank you very much, Sudeep, for great insight as to what should typically go in anyone's mind while managing such patients. And if I may ask you your viewpoint on hypokalemia. We are all the time talking about hyperkalemia in a given patient of CKD, but would you want to convey this message to everyone joining us today, that hypokalemia can also occasionally be seen, especially with the kind of medicines these people are on, and that is equally dangerous. And I think it's the suddenness of anything. If the heart is not used to acclimatize to hyperkalemia, is going to find it very difficult, and so is the case if the heart is not used to a low potassium levels. That's going to be equally dangerous. And I think it's always, even in patients who have relative hypokalemia, just because he or she has a kidney disease, we are all the time telling them not to eat fruits, take juices, coconut water, not realizing that that patient actually needs those. So your views on relative chances of and concerns with hypokalemia.
So, sir, as you've rightly pointed out, even hypokalemia, especially in early stages of chronic kidney disease for patients who are on diuretics, especially loop diuretics, are often overused. And this can lead to precipitation of hypokalemia along with, as I mentioned before, intravascular volume depletion with metabolic alkalosis. So in such cases, we have to target the underlying cause as well. And in that case, maybe the withdrawal of that drug, treatment of the volume, replacement properly, given an adequate flush with normal saline or the adequate fluid, and then follow it up with treatment of hypokalemia. Also, I'd like to mention in these, very importantly, in these patients, when we correct the electrolyte abnormalities, we have to be very, very careful, because rapid correction of electrolyte abnormalities, as we do probably in more healthier individuals, can lead to precipitation of various side effects. So, for example, if a patient is having fluid retention and we dilutional hyponatremia, you give him sodium chloride and NS. So that itself can precipitate further volume retention and pulmonary edema. Similarly, if you correct sodium too rapidly, central pontine myelinolysis can happen. And especially with rapid correction of potassium, one can also have arrhythmogenic complications if it goes too high, especially in advanced stages of chronic kidney disease, if one is over treating hypokalemia as well.
So we'll bring in Dr. Sribhushan Raju with all his experience. Dr. Raju, I can see you back in your car one more time. In between, we had seen you in your office. So I know, and I can't thank you enough for taking your time out during this busy schedule of yours. But your first take. How often, Dr. Raju, do you believe is the inappropriate dosing being done in your patients? Is it very common? Or are you very happy with where we are vis-a-vis where we were about, let's say, a couple of decades ago? You mean, what I mean to know is, do you find that the practice patterns of the physicians have improved over a period of time with the better knowledge so that there are fewer mistakes being committed? Or do you believe it's still as rampant as before?
So good evening, everybody, and thank you very much for kind opportunity given to me. And I thank especially Dr. Kullar sir for calling me and affectionately and inviting me to this particular program, which is actually very, very important and interesting topic for me also. In fact, I would have been more better after 10-15 minutes, but still it's okay, no problem. But still I'll be able to answer. And I have been listening to all the previous speakers also, and also the wonderful slides prepared by the other speaker. And very good. And it is basically intended to make the primary physicians understand about what are the common mistakes which they do as far as the kidney disease are concerned. And as far as your question, sir, and basically we were not comfortable with some of the Cockcroft and Galt based GFR methods, and where we were adjusting the doses accordingly. Even now I get confused when my students are, especially the in MBBS and internal medicine students, they come to me in a critical care where the acute kidney injury, the student sits comfortably in a near a table and just opens the book and starts calculating all the GFRs with Cockcroft and Galt formula and tells me that, sir, this the GFR is this much and today is this much. But I can tell him that with an acute setup, usually the GFR is of no value, and adjusting the doses according to this particular GFR may not be actually sufficient, and you will be either overdosing or underdosing the patient. So this is one mistake which most of the physicians do in a critical care setup in ICU, depending on the Cockcroft and Galt formula, and also the textbooks of medicine and nephrology, which they give as a pocket insert, where as per the GFR, according to the GFR, they change the doses. So that also sometimes may make a mistake, and it has been changing over a period of time. And most of them are being adjusted according to the CKD EPA formula. And Cockcroft and Galt was used before, and it was approximations only. And more so a situation where the patient is on regular dialysis. That also is very, very difficult. And sometimes some of the drugs have to be given or supplemented after the dialysis. There's a one. And another critical situation or important situation is the CRRT. So again, the dosing of the drugs probably will go haywire and with the CRRT. And more important is antibiotic therapy. Antibiotics are not the same doses which you give routinely for a patient who is otherwise stable and be in ICU. And here, in this particular situation, patient on CRRT or maintenance hemodialysis intermittently, the antibiotics have to be either supplemented or you need to adjust the doses accordingly. Again, it depends on the Cockcroft and Galt formula of the previous yes. So these are the common mistakes which all of us will do. Not only that, I'm trying to say that the physicians only will do. Nephrologist, even a professor like me also sometimes will. If I don't know the answer in the rounds, my question posed by student, I'll keep quiet actually. And the student will understand that sir doesn't want to answer. There were things that I don't know the answer, but he doesn't want to answer. That's what actually they think. So these are the mistakes which a drug dosing is concerned. That's what I perceive from your question, sir. Anything else in this
So,
particular
Dr.
question?
Raju, no, that's quite appropriate. So, if I may ask you, so again, going back to the question which I had in mind, how often are you nowadays encountering problems related to overdosing with acyclovir in herpes zoster, or for that matter, inadvertent use of sulfuride causing Parkinsonism in your patients, trimetazidine causing the same? Is the frequency increasing to your mind, or is it about the same or declining?
Yes, sir. Actually, the thing is that these drugs are not luckily is not so commonly used, especially the aciclovir. Except aciclovir, rest of the things are not so commonly used by them. But that's why it doesn't come to our attention in the notice also. The aciclovir, which we have been using, and many of the people routinely they are using, even for the sake of either the herpes zoster or herpes simplex virus, and even some of the other conditions like even the Bell's palsy also. Sometimes they start off with these kind of drugs and excess doses. And we have reported a few cases of aciclovir induced acute nephritis secondary to crystal nephropathy also before that. It can be not be dose dependent. It can be idiosyncratic also related to the drug, which can be complications. So we are adjusting the doses according to the GFR is very, very important, especially the other two drugs, trimetazidine and all. They should be able to adjust the doses according to the GFR as per the pocket insert. But only thing is that as for the dialysis and CRRTs are concerned, these drugs can go haywire, and we should be very, very careful. And as our experience is coming down with several of the other drugs, probably I'll not be able to comment much on the other two drugs. But my aciclovir, as far as aciclovir is concerned, and we need to adjust the dose, and we train to avoid, very, very important. If at all we need to take, we need to give them a lot of IV fluids, provided the patient cardiac and renal functions are okay and stable. Better not to push him into the risk of IV fluid overload. But IV fluids intake is very, very important when you're giving a drug like aciclovir, so that the nephrotoxicity would come down. There are some precautions which are supposed to take for each and every drug as far as the kidney is concerned. And the bottom line is that you should be very careful and adjust the doses according to the GFR, and also take a nephrologist's opinion whenever it is important.
Dr. Raju, what is your take on the appropriate use of NSAIDs and proton pump inhibitors in the context of chronic kidney disease?
When we were students, actually, the number one cause of drug-induced AKI or CKD is predominantly the NSAIDs. But over a period of time, the situation has changed for the past 15 to 20 years. And after it, for the past 5 to 7 years, it has changed. More important is the PPI, which I have been advocating for the past more than 20 years. And I was telling every lecture, wherever I go, in the public talks also, whenever I give, that PPIs are the culprits for producing kidney injury. So we should be very, very careful. Now, it actually superseded the painkillers, because the people, for a period of time, people understood that, especially the physicians understood the painkillers are the culprits and to decrease. But they simply write PPIs for each and every gastritis, which is a common question for most of the patients. So the PPI have not only that particular kidney injury secondary to the acute interstitial nephritis, but a slow and steady. And some of these patients will take it for a very, very long time. And ultimately, those patients, they develop chronic kidney disease in a subtle way. And acute interstitial nephritis, granular interstitial nephritis, these things are known with that. Not only the PPIs, they put unusual weakness and lassitude, which they used to complain before. Over a period of time, we understood that it is because of the hypomagnesemia. And some of these patients have had an electrolyte disorders also, which can lead to unusual tiredness when they have been taking a lot of PPIs over a period of time. And we understand that the PPIs in the long run also can lead to bone diseases, especially the osteoporosis, and elderly should not be given. The most common mistake of PPIs is that it should be given for only 5 to 7 days or 10 days maximum. As soon as the symptoms subside, you can stop. But unfortunately, it doesn't happen in the clinical practice. In a real world situation, most of the patients would continue to take PPIs for months and years together. I have a patient who has been taking PFA for the past more than 5 years. So he came to me with a small contracted kidneys. When I tell him that the small contracted kidneys are because of chronic PPA therapy, he did not even understand that. He did not believe that. He did not accept my statement. So which is very, very common. Unless an acute setup, chronic setup, which goes in a subtle way and doesn't manifest in a big way, it goes unnoticed and people won't believe that. PPIs are nephrotoxic, PPIs are dangerous to the kidney, and PPIs should not be given for a very, very long time. And probably some people are very vulnerable to keep PPI-induced injury, and we should avoid and recognize some people early and then avoid totally and tell them, or you can give an antacid which is actually renal friendly. As for the NSAIDs is concerned, it is known to everyone, not only the acute and chronic, but also it has got a tendency for accelerated atherosclerosis if you are taken for a very, very long time. We have an NSAID nephropathy and all we have seen, but accelerated atherosclerosis is a very common phenomenon. And even quacks in the villages, they abuse these NSAIDs, and they left and right, they give to each and every patient. They come to us with a lot of complications, especially accelerated hypertension with the fluid and water retention, the salt retention, secondary to the NSAID therapy, which is very dangerous to most of our patients, even in general population also. We should be very careful in using these two drug therapies.
Very much, and that's very, very clear and loud message from Dr. Raju that we should be very, very careful with the usage of PPIs and don't use them indiscriminately. So, Dr. Hemant, this one is for you. And finally, we are going to discuss something which we are all the time being asked as nephrologists. The um, when to stop ACE inhibitors, ARBs. No one is really talking about how long to continue. We all know that they are such impressive class of drugs which have made a huge difference to not just the condition of the kidneys in a given patient with chronic kidney disease, but also to their heart. And yet, majority of the times we are finding ways to stop them at the drop of the hat, which means that the moment GFR goes up, not realizing that it could be a physiological decline in the GFR, and you have to accept it and tolerate it for some time. They will find ways to believe that ACE inhibitors or any of the RASI blockers were not the appropriate way forward. And then the moment your patients tend to have a further decline in the GFR, the first thing which either the patient themselves asks that this drug has harmed them rather than giving them any benefit, so why not stop it? And at the same time, there are a lot of questions from you in the chat box as well. There are I let me warn everyone, there is a bombardment of questions today. So first one, Dr. Heman, please enlighten us about your thoughts on the continuation of ACE inhibitors and angiotensin receptor blockers in your patient, and if yes, you want to stop them, when would you want to stop them?
Yeah. You see, a mild predictable rise in creatinine is often an expected effect of these drugs, okay, and may require discontinuation. However, a significant increase warrants investigation and dosage adjustments. A rise in serum creatinine of up to 30% from baseline is acceptable, provided the patient is monitored regularly. The contributing coexisting factors like dehydration, concomitant use of NSAIDs or other nephrotoxic drugs should be explored. So that is equally important. And then what should be our approach? Our approach should be to reduce the dose of a ACE or ARB by 50% initially. Temporarily withhold the diuretic if the patient is volume depleted. Check serum creatinine and potassium again within 1 to 2 weeks, and then consider discontinuation if improvement is not seen and if the lab values do not return to an acceptable level. So this should be the criteria. And the CKD patients are to be educated equally about potassium restriction in diet who are on these medications. Once the creatinine has stabilized, the medication can potentially be restarted at a lower dose later on. And the goal is to find the maximally tolerated dose that provides renoprotective benefits without causing significant adverse effects. So that is my take about ACE inhibitor and ARB.
The third who has joined us today wants to know how frequently we should monitor potassium after starting RAS inhibitors, and what is that particular value, cutoff value, of potassium when you may want to stop RAS inhibitors?
Potassium, in fact, it should not rise, go beyond 5.5. That should be the limit. If it is above that, then we must reconsider the continuation of this drug.
Yeah, that's very, very important message, and I think I'm sure my colleagues here would bear with me today that the time has come where we should look at ways to continued usage of RAS inhibitors, because we know they have really helped the patient's heart as well as the kidneys a lot. In earlier, we didn't have those tools which could be used endlessly to take care of the potassium of these patients. Now that very soon we are going to have the novel anti-hyperkalemic agents, which can be very safely used on a chronic basis, notwithstanding the cost. And if we were to allow the science to prevail at this point in time, I think we should find ways whereby even if RAS inhibitors cause hyperkalemia, we should be concomitantly using those drugs which can take care of hyperkalemia and allow us to effectively use not just RAS inhibitors, but also someone asked a question, Dr. E. Babu, about Finrenon, that Finrenon has a lesser tendency to cause hyperkalemia. I think, yes, that point is well taken, but we are looking at, even if potassium goes up, let's try to find ways through dietary measures, through use of diuretics, and of course, these novel anti-hyperkalemic. But at the same time, I always allude to the fact that hyperkalemia can be a killer, and yet the traditional potassium binding resins which we have been using for decades altogether, and we are warned that they can cause some kind of constipation and colonic perforations. I personally have not witnessed that kind of side effect very commonly, hardly ever, if at all. So I think you have to have the right kind of balance as to what you are wanting to achieve in a given patient. So I did mention about diuretics. Sudeep, your take on the pertinent use of diuretics. We know the progression of chronic kidney disease does not allow the usual doses of diuretics to have an action, right? I'm giving you two scenarios. A patient having quite a significantly advanced chronic kidney disease, at the same time having significant hypoalbuminemia. And you know why I'm asking that. So your take on the pertinent use of diuretics in the patients with chronic kidney disease, especially the more advanced ones.
So, sir, diuretics, as we all know, are the cornerstone of therapy for chronic kidney disease. And as we go to advancing stages of kidney disease, chronic kidney disease, we find that fluid overload is a very important component. At this stage, the drugs of choice would become loop diuretics. And when I talk about loop diuretics, they are different in terms of their bioavailability, their dosage, and their half-lives. And as more importantly, you said, even in hypoalbuminemic states, because the diuretic actually binds to albumin and then it is secreted in the tubules. And if there is hypoalbuminemia, obviously the amount of diuretic reaching the site of its action in the proximal convoluted tubule would decrease. So also the bioavailability of, let's say, a furosemide is a little less, and the potency of action of torsemide is actually much more as compared to furosemide. So if I have to use for advanced chronic kidney disease stage 5, I have to use a diuretic. Either it will be intravenous furosemide, or I would go for torsemide, whether in the oral form or the IV form. Now, when I start these drugs, obviously volume is one thing which I have to look at, and I also have to look at the electrolytes. So we know that these drugs can cause hypokalemia, they can cause hypomagnesemia. So we have to keep into account that these electrolyte abnormalities are not precipitated and the patient doesn't suffer side effects because of that. Apart from that, obviously, I don't want the hypertension component also to be managed. So I have to see the blood pressure scenario of the patient, how he's doing in an advanced stage. Also, there is now a new entity known as what we know as diuretic resistance. And what it means is that we are continuously challenging the thick ascending loop of Henle of the PCT with loop diuretics in order to cause natriuresis. And what the kidney actually does is that the distal convoluted tubule starts to hypertrophy and it starts to reabsorb the sodium. So part of the action is actually what we are using for high loop diuretics is nullified. So there comes a stage when certain patients, and I'm sure everyone has experienced, which develop resistant edema, which is non-responsive, happens in cardiac failure, liver failure, nephrotic syndromes. So in these cases, we tend to add a second diuretic at a different site of action, which are thiazide-like diuretics. And recently, different trials are coming. For example, the CLIck trial, which has been there, where chlorthalidone has been successfully used even in the stage 4 for not even only treatment of hypertension, but also for these refractory resistant volume overloaded fluid retention stages. And we've seen good outcomes. In fact, I have seen even in stages 5, where patients are not responding and are still oliguric on torsemide and furosemide. I've added Zytanix and so on. So diuretics need to be interpreted carefully. And in the background of electrolyte abnormalities, hypertension, thiazides, sir, on the other hand, as we all know, we use pretty frequently for management of hypertension in stage 1, 2 CKD. But another word of caution, because I've actually experienced it in my OPD patients, is that look at the sodium levels when you start this drug. And if you start it in a relatively high dose, I've seen patients, especially elderly patients with chronic hyponatremia, going into acute on chronic hyponatremia and then presenting with lethargy and complications secondary to that. So also over-diuresis is another thing that can precipitate acute kidney injury with these diuretics. And as already mentioned by Dr. Sahil also, sir, before, potassium-sparing diuretics like spironolactone, which are the best friends of, let me say, our cardiology friends for heart failure with reduced ejection fraction. So those drugs, I tend to be more cautious beyond CKD stage 3B and beyond, because already the compensatory mechanism of the kidney for excretion of potassium is lost, and you use these drugs at that stage can precipitate life-threatening hyperkalemias with arrhythmias. So all in all, we have to take the complete picture, including the clinical status of the patient and other things which I have discussed for deciding the dosage.
Quite appropriate and a very nice message which you have alluded to. That's the use of clothalidone even in patients with more advanced chronic kidney disease, a paradigm shift from what we used to believe till some time back that they will not work. However, I am with you when you say that one will be more cautious in the use of potassium sparing diuretics, because we get into trouble so very often unless we have more experience with these novel anti-hyperkalemic drugs, whereby you get the hang of how best to use them, provided they become cheaper. Till then, obviously, it's better to play safe. There is this question by Dr. Verma wanting to know about herbal supplements in chronic kidney disease. May I ask you, Dr. Sri Raju, what is your take on these over-the-counter drugs and the herbal supplements? Every time someone tells our patients that these are magical potions, so why don't you take? Especially when we as nephrologists tell them we have nothing more to offer to you. It's going to be a relentless progression of your chronic kidney disease. So it's like sounding like you are doomed. And then comes in someone who gives them this high hope that look, these herbal supplements. So your take on is a very pertinent question which Dr. Verma has asked. Yeah.
Not only as a nephrologist, as a doctor, especially as an allopathic doctor, you should never comment and criticize these people who have been selling them off just like that casually. And the most critic of this particular things are the people who have been using that and the general population. It has been decided, decided by the society that most of the doctors are here only to loot the people, and hospitals are only to loot the people, and they don't allow the disease to have a prevention mode of prevention is very important, which the allopathy doctors never bother about. And these are the simple drugs which can make their life comfortable. But despite the fact that it's very well known in India since centuries, but these particular allopathy doctors, they don't allow the people to take these drugs because they are biased. And these are the common things which I hear to and listen to. I have been answering this question almost nearly two decades in the television programs and all, especially during the COVID time and even afterwards. I stopped telling the people because I was actually attacked by several people openly in the common debates and television channels and all. So these are the simple drugs they appear to be, and most of the people they indulge into that because they come very cheaper. I don't say that they are cheaper, and they are very expensive also over a period of time, and they are very toxic. And day in and day out, being in a government sector, we have been seeing a lot of patients who get into these complications secondary to these over the counter available these herbal products and all. And probably every day I will be answering this question routinely in my clinical practice whether they can do. In fact, you'll be surprised to see that I put a board also in my outpatient room that please never indulge in this kind of an jadi butia and these herbal drugs, and which can not only spoil your kidneys but also spoil your entire body also. This is the one which I displayed on my in the OPD room, so that I can tell the people that this is what you should follow that. But still the people will go and they take those drugs and come back to us. There are two varieties, two kinds of complications which we see, which I previously also I said about NSAIDs and PPIs. So one is the same acute component where we see the crystal nephropathies and also sudden toxicities, sometimes hemolysis related. And the second one is over a period of time, long-standing chronic kidney disease secondary to this kind of drug therapies. These are available very easily, and people will routinely indulge into that. I don't really go and dwell upon each and every variety of these kind of herbal products which are very toxic, and people they come to us, they show us the small bottles which contains these kind of herbal products, and they have been taking them since years, and they come to us with all the complications and all for no reason they get into. Now, that is one group which are a healthy group. The second group is the patients already having a known kidney disease, and they go out and indulge in all these activities of taking these drugs, and they come with a lot of complications, especially especially the neuropathy, hepatotoxicity, and also the bone-related disorders. And these are the very common things which we see, and we tell them that people don't listen to us. They routinely think that. So sometimes, many times, I feel the society is biased against allopathy doctors as far as this particular indulging in jadi butiya and this herbal products are concerned.
Quite appropriately answered, Dr. Raju, and I think it's extremely important. Rather than criticizing any drug, I think it's more important to know, ask ourselves the question: do we know enough about the agent which we are prescribing? So rather than using it indiscriminately, that may be a great drug, but probably in the wrong hands. So let's put it this way. So Dr. Hemant, this one is for
Yeah.
you. CKD, one common mistake. This is again at the risk of repetition of what we've discussed in our previous editions. It's extremely important that patients are inappropriately advised to restrict their protein intakes in our patients, knowing fully well that Indian diet as such is not rich in proteins. And also your take on the fluid restriction advice early versus late CKD. So many times it is like putting everything in one basket. They're saying that, okay, the label of CKD means no to proteins, no to fluids, while this may not be the case. So what is your take on such a strategy? Yeah.
Yes. For non-dialysis CKD patients with diabetes, a protein intake of 0.8 gram per kg per day is recommended. However, the KDIGO 2012 guideline recommended this for both diabetic and non-diabetic patient population with GFR less than 30 ml per minute per 1.73 meters square. However, the role of renal dietitian is crucial for a personalized approach. And regarding fluid, there is no blanket restriction for early CKD, that is stage 1 and 2. But for late CKD like stage 4 and 5, fluid restriction as recommended by KDIGO is that ranges from 1000 to 1500 ml per day, depending on residual renal function, dialysis status, and diabetic use. In all CKD stage patients, sodium intake is very important, and that should be restricted to less than 2 gram per day. That is these are the guidelines given by KDIGO.
Thank you, Dr. Hemant. Sahil, this one is for you. You said we should try to modify the dose of metformin. So what? How would you advise controlling the diabetic status in these patients with advancing chronic kidney disease? You say metformin has the dose has to be modified and then finally stopped once the GFR falls to less than, let's say, 30 ml. What about sulfonylureas? Where would you want to stop them? Which kind of sulfonylureas? Because see, at the end of the day, India is a country inhabited by a large number of poor patients, and we have to look at their affordability. And we know that sulfonylureas may be an effective and a relatively cheaper tool to control their diabetes with. So what kind of suggestions would you give to the audience today as far as the usage of sulfonylureas is concerned?
Yeah, sir, as you rightly pointed out, that most of the guidelines which are formed are in context to the larger sectors of population which will exist in a country. So, talking about that India is still a developing country, I believe most of our patients are going to either resort to no therapy, or they'll resort to alternative form, as Dr. Raju said, or the third option would be to give them something which they can afford. So in that context, I think metformin and sulfonylurea, especially glipizide and gliclazide, are the ones which are going to stay long for our patients. I would be comfortable, and most of us would be comfortable to continue sulfonylureas like glipizide and gliclazide till stage CKD5, and even in CKD5D if the time and the need warrants. So regarding metformin, as I said, even after the roaring introduction of SGLT2 inhibitors in our prescription, there was a not a I mean there was a ADA guidelines wherein they advocated that the metformin usage should not be limited by SGLT2 inhibitors, because these drugs have own niche and they are cardioprotective.
As you rightly said, that they are the drugs on which the faith still should lie upon, and they should and should be offered to kidney patients wherever and whenever possible. Less than 30 GFR, obviously, the risk of lactic acidosis increases. But to be very honest, sir, if at all the patient was not stopped at GFR 30 and he continued taking metformin, I have not come across a patient who landed up with severe lactic acidosis in my OPD at least. I mean, I'll just be talking about my small personal experience, but small anecdotal experience shouldn't be equated as a guideline. So I would still say that what the experts and the key opinion leaders have told, that at less than 30 GFR metformin should be discouraged. We would follow and stick to that. In that case, use of linagliptin and glipizide and gliclazide is what I would still recommend. Voglibos is another drug which I think can be used in patients who have postprandial excrusions in in their sugar charting. And obviously, use of insulins at this point of time would be convenient and should be promoted.
So you mentioned about SGLT2 inhibitors, and I do recognize the fact that no discussion pertaining to chronic kidney disease can be complete without mentioning about SGLT2 inhibitors, and today is no exception. Dr. Raju, if I may ask you, uh, SGLT2 inhibitors in advanced CKD, we knew we were coming down as far as the level of GFR was concerned with every next trial, starting from Credence to DAPA CKD to AMPA kidney. We moved beyond diabetes, and any CKD would certainly benefit from. But what is your take? And that's a question by Dr. Zaveri as well. When to stop SGLT2 inhibitors? The question here is in the context of non-diabetic CKD. Is it better to stop it in patients undergoing minor surgery? Is what the question is. But then my take on the question to you is SGLT2 inhibitors in advanced CKD. When would you want to stop them?
So initially, when these drugs started, when we started doing the credence trial, I was very skeptical about how much would be the benefit of these particular drugs. And without knowing about it, suddenly I had to one day go and give a talk about how the SGLT2 inhibitors act for a group of cardiologists initially. Even I got surprised that I accepted the particular topic, and I went and realized that this is the topic which I was supposed to talk about. It was around 12, 11 years back. So I got surprised that this particular molecule has made some important started playing some important role in the proteinuria conditions, diabetic kidney disease and all. Now the CKD. Not only that, actually now it went up to ESRD. Not only the ESRD on maintenance hemodialysis, then also on the peritoneal dialysis. Now we did not stop there, and now it is into the post-transplant scenario also. We have been using it in a significant good number of people actually. So especially one of the questions of yours, the post-operative, what's the very problem of these particular drugs is that actually severe dehydration it produces, and unusual amount of lassitude and the weakness it produces, the lethargy. Mostly it is contributed predominantly by probably the dehydration, but some of the electrolyte disorders also can really contribute to that. So better to avoid in those patients vulnerable. I always tell my students and other people also that to avoid these SGLT2 inhibitors in too elderly population and aged people, very aged people who are emaciated and sarcopenic, and also the elderly woman who had few episodes of urinary tract infections already before. Even if they are middle aged, if they had a abnormal urinary tract and with a stone disease, and those patients who had a tendency for urinary tract infections before, chronic smokers, though who have a risk for the peripheral vascular disease, and these are the group of people which I always try to avoid, and tell my students also not to immediately prescribe. If you prescribe, they'll come back to you with some other complications, especially the UTI and the worsening of cellulitis over the lower limb, and also the worsening of peripheral vascular disease in the patients. So better to avoid this kind of a group of people. And perioperatively, if you think that the patient is vulnerable for any of the complications of whatever I mentioned, you better to stop that. If not, if at all if they are very good and you are supposed to continue that, see that the hydration status of the patient is very well maintained, and so that uh, you can continue with the particular drug without major complication. So, but SGLT2 inhibitors have been used, and ESRD, another question, part of your question is that ESRD, which I feel we have been using it even on the peritoneal dialysis. Literature is there, but I did not use, but the literature also is there with the peritoneal dialysis and maintenance hemodialysis, and I can say that GFR of more than 20, I have been using it, and also the post-transplant scenarios I am using it, and CKD, non-diabetic CKD, both I am using in this particular group of people, and very rarely I had to stop at least one or two, maybe the indication itself is actually I have a strict criteria when not to start. So probably that is the reason why I did not stop in good number, and except one or two aged people where the patient was prescribed this particular drug outside, and I had to stop because of the several multiple complications, especially the symptoms of the patient, especially weakness and all. Otherwise, these drugs are okay, and we had to see for a long time.
So very, very important point made. And I think most of these trials say that, yes, you can start them at a GFR of 25, as in case of DAPA CKD, or 20, as in NAMPA kidney. But they don't ask you to stop the moment it falls to less than 20. You are supposed to stop it only once your patient goes on to a stage of dialysis or undergoes transplantation. So which means, and as was the case with DAPA CKD, even though the numbers were very, very small, even those patients who were continued on SGLT2 inhibitors even after they had reached a stage of dialysis, they were found to have some protection from the cardiovascular disease, as far as those patients were concerned. So I think sky is the limit for SGLT2 inhibitors, but point well taken. There is a risk of euglycemic ketoacidosis. So you should stop them ideally about with 2-3 half-lives, which means 4 or 5 days prior to a planned surgery, and then stop them only after about 72 hours of the surgery, so as you don't fall in the trap. Well, I think I'm really enjoying this discussion, but then time always comes in the way, and I think I'll have to stop here. I'll just want to take a quick one or two questions. If time, I can't say time is allowing. It's already not allowing us. But Dr. Chalani wanted to know how to differentiate AKI in CKD receiving SGLT2 inhibitors and RAS inhibitors. Sudeep, can I ask you to take it up? Trying to differentiate between physiological decline in the GFR and the true AKI in these patients, unless you have persisted in a patient who was already dehydrated, and on top of that, you give these kind of agents. Otherwise, it's a very, very strong message which you can deliver today to have that kind of confidence, even if your patient has some decline, which could be physiological decline in the GFR. Yeah.
So, sir, as we all know, and it's already been talked about, with RAS inhibitors, there is a 25 to 30% expected hemodynamic dip in GFR, which is due to the efferent arteriolar vasodilatation, which leads to decreased intraglomerular pressure and hypertension. More so, a little less as compared to a little more as compared to SGLT2 inhibitors, where it's a little less, where studies have shown 3 to 6 ml per minute per meter square of decline is there. Now, the main challenge for a nephrologist and also all other clinicians is whether this is a true AKI or whether this is a pseudo AKI or a hemodynamic dip that we are talking about. So for me, how do I differentiate and what are the parameters? So if the AKI is acute and it starts within 1 or 2 days, then it's more likely to be a true AKI. If it's more severe, that is that if the fall in the GFR is more than 30%, in the first 1 or 2 weeks of starting that drug, you have to look at concomitant factors. Apart from that, some kinds of AKI are oliguric. So usually when we initiate these drugs cause, they do not cause oliguria almost in all cases. So if you have a fall in urine output of less than 400 ml per minute, then it's more likely to be a true AKI. Also, if it is associated with clinical symptoms, for example, you have swelling in the legs, you have puffiness, then there are signs of muscle weakness, nausea, vomiting, and in turn, there are electrolyte abnormalities. For example, hyperkalemia is there because of the AKI, then it's more likely to be a true AKI. And when you see these scenarios, almost in all cases, we will find that there are concomitant factors which are precipitating AKI, as you said. For example, intravascular volume depletion is there. Patient is having sepsis in the background. Patient is having blood pressure fluctuations, or it's on a nephrotoxic drug or contrast agents which are causing the AKI. Also, AKI would progress. So even after 1 to 2 weeks and a 30% decline, if you are still confused whether it's due to the SGLT2 inhibitors or ACE inhibitors or a true AKI, this will continue to progress unless you address the cause of the acute kidney injury and you treat it. So it is very important because at this stage, we have to take the decision to stop the drug or not. And if we stop the drug because of this challenge, then we are missing out on the long-term cardiovascular and renal benefits. So a few of these points that we take into account while we manage this AKI, and most importantly, before we start treatment, see the baseline creatinine, see the baseline potassium, 7 to 10 days after initiating the drug, see these values again. If you think you are still confused whether it is true AKI or maybe a hemodynamic dip, repeat it after 1 week. And once in the case of the drugs, it is supposed to stabilize after 1 to 2 weeks, and it tends to plateau or slightly decrease for maybe SGLT2 inhibitors. And then you can go on monitoring the renal function monthly if it has stabilized.
Well, thank you very much. So it's time is up. I think I am really, as I said, enjoying this discussion. But thank you very much, everyone, for joining and addressing this very, very important aspect of management of CKD, where we can all go wrong. And I think we need to remind each other as to what better can be done. Thank you very much. And one more time, I would like to thank Intas for this wonderful initiative, and especially because of the fact that as was mutually agreed upon, there was this understanding that there's going to be no branding here. So full marks to Intas for doing it purely as an academic exercise. And as you can see, absolutely no branding here. So that speaks volumes of the intentions behind such an exercise. So Gaurav has already informed me that close to 1,800 people have joined us even today. Thank you very much for sharing your enthusiasm about learning the aspects of chronic kidney disease with us. Over to you, Dr. Mithilesh, for the concluding remarks. I'm extremely sorry one more time to overshoot the allotted time, but I thought really that it is extremely important that we extract maximum out of my dear friends today who have joined us, to be able to share their knowledge with everyone who has joined us today. Thank you very much.
Yeah, thank you, sir. So, on behalf of Intas Pharmaceutical Limited, it's my pleasure to offer a vote of thanks. So, first and foremost, I want to give my heartfelt thanks to our speaker, Dr. Sahil Bagai, for delivering an insightful and impactful talk. We are equally grateful to our esteemed panel member, Dr. Hemant Kumar, Dr. Raju, and Dr. Satdev for their thoughtful contribution and for bringing valuable clinical perspective to this engaging discussion on the common mistakes while managing the patient of CKD. A special note of appreciation goes to our visionary course director, Dr. Fuller, sir, whose guidance is continuously inspiring us to making this academic platform go further, providing the immense value to our audience. Our sincere thanks also goes to our audience for their enthusiastic participation and continued support. We look forward to welcome you again in our next episode with yet another important topics which further enhance our understanding about the better management of chronic kidney disease and other kidney disorders. With this, thank you and good night to everyone.
Thank you, sir.
Thank you very much.
Sir.
Good night.
Thank you.
Thank
Thank
you,
you,
Thank
sir.
you, everyone.
Thank you very
Thank you,
much.
Dr. Mithilesh. Thank you.
Thank
Thanks,
you.
sir. Thank you, Dr. Mithilesh. Thank you, Dr. Fuller. Thanks, sir.